or trunk of the brachial plexus, C5 and C6, and go posteriorly through the omohyoid and go posteriorly laterally under the trapezius in the suprascapular foramen notch, and then go laterally deep to the muscle to the sphenoglenoid notch. It's a sensory, it's motor. Shoulder pain is very common in your practice. Post-surgical, non-operative pain. Patient have some entrapment in neuropathy. They have, especially if it's suprascapular notch, their infraspinatus muscle will be weak, frozen shoulder, post-surgical pain. Give you, I mean, it's not the only nerve, there's many nerves, as you know, covering the shoulder, but it will give you a good 50% of the covering, especially the posterior lateral. But recently, it's a great target, and I implanted. It's good for only fluoroscopy. If you're not comfortable with ultrasound, you can do only fluoroscopy, very successful. But recently, the last 3-4 years, a lot of anatomical data came to kind of underestimate our thought about the suprascapular nerve. It's the major nerve of the shoulder. The majority, 70% of supply. Those are a little bit myth. That 70-80% of the shoulder supply by the suprascapular nerve is actually less than 50%. Recent many anatomical articles in the region and chronic pain also. Maybe just 30-40% or so if you can get, like, with many nerves, not only the suprascapular axillary, pectoral nerves, subnerve to subscapularis, other branches from the brachial plexus, other branches from T1 and C3, C4. So that's why I started more to go to brachial plexus for the shoulder pain than suprascapular. So I use less suprascapular now. But for the brachial plexus, you have to be very comfortable with ultrasound and neck anatomy also. But it's very good target with X-ray, relatively safe unless you go to the lung. So ideally, we go from medial to lateral. So have the navigation prone, get the AB, and then oblique your X-ray towards the head, good 30, 40, 50 degree. So you will degree cephalad tilt a lot, just to expose the notch. Because if you do straight AB, you're gonna just see the spine of the scapula. So just move cephalad tilt, good 30, 40, each patient is different, till you start to clear up the notch. The notch is just medial to the coracoid. If you see the coracoid is like the ball in the middle, just medial to it, you're gonna see the notch. And sometimes you need the ipsilateral tilt. Go cephalad a lot. The X-ray sometimes go all the way cephalad and toward you, ipsilateral. And then you go from medial to lateral, safer, just to touch the spine of the scapula, or the scapula itself, the scapular border itself, the border, the anterior border of the suprascapular notch itself. But usually the bone quality is not that good, so you won't see the anterior border of the scapular border well. You see just the spine of the scapula. But this is the spine, but behind the spine here, there is the posterior aspect, which also, if you go through it, if we didn't see it well, you can be like in the lung. So just be careful. So touch the bone, be comfortable. Yeah, bone, I'm happy. Then move laterally. You want to have your leads just below the notch itself. Maybe one contact, proximal, one contact distal. But I use ultrasound. But I use it less and less because I go to the brachial plexus.
You have the arm flexed here and under the head, or just to the side? To the side.
Your first incision will be around like T3, T2, just lateral to the spinous process. You go medial to lateral, and then where your second incision, you have to be creative. Your first incision will be here. So your second incision either will do like a 90 degree and put it down, or you can cross it to the other side. Especially in bilateral cases, you can have one incision here, and cross them for bilateral cases. Or do 90 degree and do it down. And the patient will do it in the bra, or they have different wearable. One approach that it was make sense to me, but challenging. I did it one time, and some colleagues do that. You go from actually the sphenoglenoid to the suprascapular notch. So you enter from down here. You go to the sphenoglenoid because the nerve is going from the brachial plexus to the suprascapular notch to the sphenoglenoid notch. So the nerve courses that way. So if you want to put parallel, when you put the lead like that, you're not parallel to the nerve. You are just 90 degrees to the nerve. So if you go from down up, so you get parallel to the nerve, your lead will be inside the canal itself. So it will be like stable. You will not like move. But technically, challenging to go inside to the outside. It's not easy. And also, you may risk entrapments because you're gonna put the artery and the nerve and the lead both are in the same, competing for the same space. I did it in a couple of cases. I go here and then put one lead, suprascapular, and you can put one lead to axillary from the same. Like, you remember this guy?
Yeah,
He's
unfortunately,
dead.
he had a heart
He's
attack
dead,
after his stroke.
yeah. So I did another one also with another company, but it's you may increase the risk of entrapment, and it's not easy. Also, this is easy. Okay.
Do you always combine it with the axillary or just do suprascapular?
Depends on the pathology. Like if this mainly posterior only entrapment, I would just only the suprascapular.
If they have lateral also, you get axillary.
And then do like RFA, the lateral pectoral,
How to cover the interior?
yeah.
It will not
Right.
cover it well. You will not cover the interior with this, but this will give you like good 50%.
Yeah.
But that's, as I told you exactly, I moved a little bit farther. I moved to the brachial plexus to give the anterior, lateral. I put like a C5 and 6 nerve root. If you put at the C5 nerve root, you will cover the majority of the shoulder support. Suprascapular, the axillary, many of the pectoral nerves. You put like a one lead C5 and 6, another lead C7. No, you will get most of the shoulder. But you have to be comfortable with ultrasound, brachial plexus, comfortable putting the neck close to the vessels.
How do you prevent migration in the neck?
But you have tines, you suture, then you have tines. And if you go from posteriorly, you're going from posterior, not from anterior. It's not like injection from the front. You go from the back. We can scan and I'll show it to you.
Yeah.
With like a decent success. I think I have images.
I think that was the last slide of the core 5 nerves. Is there anything else you guys would like them to talk about? I know like we said, there's a